Hello students. Today we are going to discuss pharmacotherapy of bronchial asthma. First we have to understand what is bronchial asthma. So let's begin with the introduction. Bronchial asthma is an episodic narrowing of the bronchi thought to be caused by underlying chronic inflammatory disorder which is mainly initiated by two things. One is airway inflammation and second is bronchial hyperactivity. Now we see the pathophysiology of the disease. Bronchial asthma occurs either because of the genetic predisposition, which means certain asthma runs into the family, and second is the acquired disease where the list of agents or events will trigger the asthma, which is not genetically transmitted but patient is sensitive to certain agents or events. These are listed here. Some of the respiratory infection may trigger the asthma. Allergens like pollens, dust, colors, certain fumes, any type of allergen can trigger the episode of asthma. There are certain environmental factors like excess of carbon or chromium or nickel into the atmosphere can trigger the asthma. Emotions, anxiety, stress, laughter can trigger the asthma, which means asthma is also having some kind of psychological origin. In some of the sensitive individuals, vigorous exercise may lead to asthma. Drugs and certain preservatives may lead to development of asthma, and occupational stimuli like someone will be allergic to chalk which is used for the teaching, then he may or she may develop asthma because of such kind of stimulus. So asthma can be divided into two categories. One is genetically predisposed and second is non-genetic, which is acquired because of the infection or the agent or the events occurring into the surrounding of that patient. So what are the risk factors and trigger? Bronchial asthma can be because of the endogenous factors like genetic predisposition, atopy which is a type of allergic condition which is there into the individual, airway hyperresponsiveness, it is more common into the female gender and obese individuals are more prone to development of bronchial asthma. There are certain environmental factors like indoor allergen, allergy to house dust, allergy to rodents, that are the indoor allergens. There are certain outdoor allergens like certain pollens or fumes, occupational sensitizers like exposure to heavy metals, passive smoking, this would trigger the bronchial asthma. And actual triggers are allergens, viral upper respiratory tract infection, exercise which leads to hyperventilation, cold air, irritant gases, drugs like beta blockers and aspirin can induce asthma, stress, and spray, paint, and other irritant substances can directly trigger or initiate the bronchial asthma. In asthma, two, three things are very important pathophysiologically, which I am going to describe in brief. First is airway inflammation, which is triggered by innate or adaptive immune response. Second is lymphocyte directed eosinophilic bronchitis, which is hallmark of diagnosis for the bronchial asthma. If you take out the bronchial secretion through the bronchoscopy and look it under the microscope, into that secretion you will find the lymphocyte directed eosinophilic bronchitis. And one of the other important factor is bronchial hyperactivity. What is bronchial hyperactivity? In asthmatic patients, the concentration of bronchial spasmogen like histamine or methacholine. Histamine is an allergic mediator which is released when there is allergy and it has tendency to cause bronchospasm. So concentration of histamine required to produce bronchospasm is 20% increase into the airway resistance, that is the bronchospasm, is only 1 to 2% of the concentration that is required for the healthy patients, which means if a healthy individual requires 100 milligram of histamine to produce bronchospasm, asthmatic patient will require only 1 milligram of histamine to produce the same amount of bronchospasm. That is called as bronchial hyperactivity. which means even a small quantity of allergen can produce the exaggerated response. That is why the word hyperactivity is very important here. These are the pathological changes which occurs inside the bronchial wall of the asthmatic patient. This is the respiratory tract lumen and this is the airway wall. Into the lumen there is a ciliated columnar epithelium into the whole respiratory tract, if you remember from the first year lectures. Whenever any allergen which comes through the respiratory tract, it will come in contact with this epithelium first. Initially the cilia will try to remove that allergen, but once allergen enters inside the cell, it comes into the contact of the epithelium, it will lead to epithelial shading and it enters inside the cell. When it enters inside the cell, it produces the allergic response, and this allergic response will stimulate the mast cells or basophil, it will activate the macrophages and dendritic cells, it will activate the T helper cells, eosinophil, and ultimately cytokines and chemokines are released from this inflammatory cells. So initially the allergen will produce the inflammation, and there is a release of cytokine, chemokines and inflammatory mediators. Inflammation process you have learnt in pathology, so we are not going into detail how these cells will produce the inflammation. But inflammatory mediators are leukotrienes, prostaglandins, purines, histamine, proteases, platelet activating factors and certain protons and many more are there. But we are actually not going to see this inflammatory mediator into the bronchial tree. If the patient of asthma comes to you, you are not going to look into the airway for the mediators, but you will be looking for the consequences of this inflammatory mediator, which include epithelial shedding, sensory nerve activation and plasticity of the nerve. So nervous control of the airway is little bit disturbed. There is subepithelial fibrosis formation starts. There is a leakage of the plasma from the capillaries which is supplying the airway wall, and there is edema of this airway wall. There is a hyperplasia of the mucus secreting gland onto the surface which will secrete the more amount of mucus and secretion, which is responsible for development of mucus plug. There is vasodilatation and angiogenesis which will lead to hyperactivity of the cell, parasympathetic nerve activation and plasticity which is supplying the smooth muscles, and it ultimately causes bronchoconstriction of the airway smooth muscles and bronchial hyperactivity. So here first is allergen comes into the contact, it will produce inflammation, it releases the inflammatory mediator and the consequences are there. These consequences are epithelial shading and subepithelial fibrosis, nervous control of the airway wall is disturbed, there is a leakage from the plasma capillary and formation of the edema, vasodilatation and angiogenesis, bronchoconstriction of the smooth muscles of the airway, mucus secreting glands are hyperactive, there is hyperplasia of the gland which secretes more amount of mucus, and ultimately mucus plug and secretions are there into the respiratory tree. Along with the secretion with the bronchoconstriction, there is an acute bronchospasm which will be reflected as an acute episode of bronchial asthma. Now we see the classification which is based on the etiology. Asthma is divided into two categories. One is extrinsic or allergic asthma and other is intrinsic or idiosyncratic asthma. In allergic asthma, usually there is history of atopy into the childhood, family history of allergies is present, there is positive skin allergy test is there. If you do the IgE level examination of the patient, there will be raised IgE level. It usually starts below the 30 years of age and patient is less prone to status asthmaticus, which is the severe form of asthma. While in intrinsic asthma, there is no family history of allergy, skin test is negative, there is no raised IgE level, usually middle age onset is there, and these patients are more prone to development of status asthmaticus. Now we start with the pathophysiology. This we have discussed in detail in the previous slide, so this is just a repetition. So whenever stimulus come, there is antigen, virus, pollutant or occupational agent. It starts the acute inflammation, altered airway pathophysiology, increased airway obstruction, and this acute inflammation resolves or it goes into the phase of chronic inflammation, which will further enhances the airway dysfunction, and over a period of time this chronic inflammatory injury will repair and there is remodeling of the airway and there is a long term structural and functional changes into the airway occurs which make the airway permanently disabled. Permanently altered lung function will be there. So if an acute attack of asthma is not taken care of in time, it may lead to chronic variety and that would lead to permanently altered lung function. This is just the same into the another phase. This is the normal bronchus, this is the inflammatory phase, and this is the spastic phase when as a long term there is a smooth muscle hyperplasia, bronchial gland, secretory gland hyperplasia, excessive mucus and narrowing of the airway. So how the patient is presented to you? Clinical presentation is symptoms. Patient describe as I am having episodes of dyspnea, chest tightness and coughing, particularly at the night time, along with wheezing or a whistling sound when breathing, which is maybe having association with the exercise or it may be spontaneous or it may be associated with known allergen. But patient gives history of breathlessness, I am not able to breathe, having cough and chest tightness along with the wheezing or whistling. And when you examine the patient, signs are expiratory wheezing on auscultation, dry hacking cough is present and signs of atopy or allergic rhinitis or eczema is there. When you go for the investigation, first is spirometry, where you find the obstructive picture, that is reduced FeV1 upon FVC ratio and reversibility following inhaled beta 2 agonist administration, and it shows at least 12% improvement in FeV1, which is suggestive of bronchial asthma. So ultimately patient gives shortness of breath, recurrent episode of wheezing, tightening in the chest and coughing. So what are the approaches to the treatment? First is bronchodilation. If bronchi are constricted, first thing to provide oxygenation is you have to dilate the bronchi. Then only patient can breathe. So drug can which produce the bronchodilation are sympathomimetic, anticholinergic and xanthines. Suppression of inflammation is required where you can use corticosteroids. Prevention of the release of mediator which is achieved by mast cell stabilizer. Antagonism of released mediator like you can use leukotriene antagonist, histamine antagonist, etc. Neutralizing antibodies like omalizumab and prevention of antigen antibody reaction, that is prevention of the allergen exposure. We first start with the bronchodilators. You have learnt into the ANS that adrenaline causes bronchodilation. All sympathomimetic drug can produce bronchodilator. Non-selective sympathomimetic drugs are adrenaline, isoprenaline, ephedrine. They can produce bronchodilation, but they are not used for the treatment of bronchial asthma because the action is non-selective. Adrenaline will not act only on the respiratory tree, it will act onto the heart and other organs which will produce the side effect. That is why they are not used for the treatment of bronchial asthma. Instead, we are using selective beta 2 receptor agonist for the treatment of bronchial asthma as bronchodilators. As you all know that respiratory smooth muscles are having beta 2 receptor and stimulation of beta 2 receptor will produce bronchodilation. So selective beta 2 receptor agonists are salbutamol, terbutaline, formoterol. They will be used as a drug of choice. Anticholinergic M3 receptors are located into the bronchial tree. Ipratropium bromide can produce bronchodilation, but it is used as adjuvant. And methylxanthine, which include theophylline, aminophylline, doxophylline, etc., they are used as adjuvant. So in bronchodilator bronchodilator, we have four categories. One is non-selective sympathomimetics like adrenaline, which are not used nowadays because of their non-specific action and adverse drug reaction. Selective beta 2 agonists, they are drug of choice like salbutamol. Anticholinergic ipratropium bromide, they can be used as adjuvant only, and methyl xanthine can be used as adjuvant only. We start with the beta 2 agonists. Selectivity is not absolute and it is usually lost at high concentration. Classification of selective beta 2 agonists are shorter acting drugs which include salbutamol, terbutaline and pirbuterol, and longer acting drugs are salmeterol and formoterol. Shorter acting agents are preferred for acute attack because once the acute attack is terminated, there is no further requirement of the bronchodilatory action. So, shorter acting drugs are usually preferred for the acute attack like salbutamol. What is the rationale of using this beta 2 agonist into the bronchial asthma? They produced beta 2 mediated bronchodilation. They stimulate the beta 2 receptors are G protein coupled receptors and they stimulate the GS adenyl cyclase cyclic AMP pathway as a second messenger, which produces reduction into the smooth muscle tone. They also increase the conductance of calcium sensitive potassium channels and produces hyperpolarization and relaxation of the bronchial smooth muscle. They also act by inhibiting the function of inflammatory cells. They inhibit the release of inflammatory mediators and cytokines from the mast cells, basophil, eosinophil, neutrophils and lymphocyte. But this action is very much less limited or it is not observed clinically. The main important action which is responsible for their use into the bronchial asthma is bronchodilation. Route of administration, the drug can be administered by inhalational, oral, subcutaneous or intramuscular routes. Onset of action is 1 to 5 minutes for inhalational route and duration of action is 2 to 6 hours for inhalational route. Salbutamol is the most widely used beta 2 agonist for the asthma. Acute attack of bronchial asthma means salbutamol. Drug of choice is salbutamol. Whatever is the cause, you first have to give salbutamol. It relaxes the bronchial smooth muscle regardless of the agent which has produced the constriction. The dose is 100 microgram per puff meter dose inhaler. Maximum person can take 8 puffs a day. It is also available as 2 milligram and 4 milligram tablet and maximum 16 milligram per day can be given, or you can give the salbutamol till the patient's heart rate reaches 180 beats per minute. That is why inhalational route is preferred because it is having less systemic side effects. This is how the drug is administered by inhalation route. You use the device like meter dose inhaler or nebulizer or a rotahaler where 90% of the drug will be deposited into the mouth and it will get swallowed. But rest 10% of drug will reach the lung and produce the topical absorption effect, that is 2 to 10%. Whatever drug is gone orally, it will go into the first pass metabolism and it leads to inactivation of the drug. It further get absorbed from the GIT, it goes into the bloodstream and metabolized and converted into inactive metabolite and excreted. But this, even though the 10% of drug will be going into the lung, that is sufficient to produce the bronchodilatory action. Devices which is available for inhalation route are meter dose inhaler, nebulizer, dry powder inhaler or rotahaler and spacer, which you have learnt into the practical sessions and you will be given a demonstration on them into your practical sessions. Factors governing drug delivery by inhalation route is the particle size. Optimum particle size is 1 to 5 micrometer. If the particle size is more than 5 micrometer, the chances that the particle will be settled down into the mouth when you try to inhale. If the particle size is less than 1 micrometer, then it will get inhaled but it will be exhaled out with the next expiration. So optimum particle size is 1 to 5 micrometer. Other governing factor is inspiratory flow rate, that is how much patient can inhale. breath holding time, which will allow the drug to go into the alveoli and the desired site of action, and proper technique of using the device. Adverse drug reactions of beta 2 agonists are tremors, tachycardia and arrhythmia, and myocardial ischemia, which is pertaining to the stimulation of beta 1 receptor. It can produce CNS side effects like anxiety, apprehension, feeling of restlessness. It may lead to ventilation perfusion mismatch and severe pulmonary edema into certain sensitive individuals. It can lead to increased concentration of glucose, lactate, free fatty acid, and hyperglycemia may worsen into diabetic patients, and it may lead to hypokalemia and muscle pain as a side effect. So side effects of the beta 2 agonist are extension of the pharmacological actions only, as well as when the selectivity is lost from the beta 2 and it will be acting on beta 1 receptor, then this side effect would be there. Next category of the drug useful for bronchial asthma is anticholinergics. Example is ipratropium bromide and tiotropium bromide. They are muscarinic receptor antagonist. M3 receptor is responsible for the bronchoconstriction into the asthma patient. These drugs are having slow onset of action, less intense bronchodilation as compared to beta 2 agonist is produced. The response is very variable with the anticholinergic drug, which is mainly reflecting the differences in the parasympathetic tone and into the degree to which the reflex activation of cholinergic pathway participates in generating symptoms into the patient. So if the patient is having high underlying parasympathetic tone, then anticholinergic would be helpful, which is a case into the COPD, which is not very much important into the asthma patients. Ipratropium and related compound will block all 5 muscarinic receptor subtypes. If you remember, muscarinic receptor is having 5 subtype M1, 2, 3, 4, 5. Tiotropium bromide is a selective antagonist for M3 receptor and it will selectively block M3 receptors only. It has affinity for all receptors but dissociate from the M3 receptors very slowly, and it is a longer acting drug. It is given by inhalational route, can be given once or twice daily. What is the current therapeutic status of anticholinergic drug into the treatment of bronchial asthma? They are helpful in asthmatic patient who develop psychogenic exacerbation. It can be given as a combination therapy in patients who are not controlled with beta 2 agonist alone. COPD, acute stage management, and for the prophylaxis, they are also very useful. Next category is xanthine derivative, that is theophylline. It is belong to methyl xanthine group. Example is caffeine, aminophylline, etc. It is least expensive drug used into the treatment of asthma. It is having low solubility, that's why it is available as complexes with other compound into the ratio of 1:1. Like aminophylline is a combination of theophylline and ethylene diamine in 1:1 formulation. What is the mechanism of action of xanthine group of drugs? Theophylline are non-selective phosphodiesterase enzyme inhibitors. They inhibit the cyclic nucleotide phosphodiesterases. So they inhibit the breakdown of cyclic AMP and cyclic GMP to monophosphates. If you remember from the lectures of general pharmacology, phosphodiesterase is the enzyme which is responsible for breakdown of cyclic AMP and cyclic GMP. So when this enzyme is inhibited, accumulation of cyclic AMP and cyclic GMP into the airway wall, which lead to increased transduction through this pathway and ultimately produces bronchodilation. Phosphodiesterase 4 enzyme is selective for the bronchial tree, and Silomilast is a drug which is newly developed for the asthma therapy. It is comparatively high selective than theophylline for the asthma. But in general, all the xanthine derivative are narrow therapeutic index drug. They are given either orally or parenterally IV. Dose of theophylline is 15 mg per kg per day or 100 mg 3 times a day IV. Aminophylline 7.5 mg per kg per day IV or 250 to 300 mg oral or IV. Doxorubicin, it is a longer acting drug which is given as 400 mg once or twice a day. But the drug is very toxic. It requires dose reduction into the patients of more than 60 years of age, renal impairment patient, heart failure patient, pneumonia and liver failure patients. Current therapeutic status of xanthine in asthma therapy, it is not at all used currently. It is only reserved as a third line therapy into the patients those who are not controlled with other drugs. Why so? Why it is not commonly used? Because of its side effects. The side effects, when it is injected rapidly IV injection, as a rapid IV injection, it produces fatal cardiac arrhythmia. Xanthine will produce cardiac arrhythmia, and even before you complete the administration of a single syringe or 5 to 10 ml of drug, patient goes into the ventricular tachycardia or other arrhythmia and death is possible. So that is why drug is always given IV very slowly over 20 to 40 minutes with the cardiac monitoring facility available. It produces headache, palpitation, dizziness, hypotension and precordial pain. Nausea, vomiting, restlessness, agitation and seizures have been precipitated. It produces behavioral disturbances also. Next and very important drug into the treatment of bronchial asthma is glucocorticoids. So till now we have discussed about bronchodilator drugs which included beta 2 agonist, anticholinergic and xanthine derivatives. Now we shift to the anti-inflammatory drug. So we have covered the bronchoconstriction part and the drug useful are bronchodilators. Now we are discussing the drugs which are targeting the inflammation, and the first is glucocorticoids. Systemic glucocorticoids has been used to treat the severe asthma or acute exacerbation into the past, but because of the systemic administration there were lots of adverse drug reactions. Development of aerosol delivery system for the steroids have changed the treatment protocol for the bronchial asthma like anything. Asthmatic subjects who require inhaled beta 2 agonist 4 or more times per week are viewed as the candidate for inhaled glucocorticoids. What is their mechanism of action into the bronchial asthma? Into the asthma, we have seen that there is a airway inflammation, airway hyperactivity and acute bronchoconstriction. Glucocorticoids do not directly relax the airway smooth muscles. They have little effect on acute bronchoconstriction. They cannot dilate bronchi. They can only suppress the inflammation. Glucocorticoids are not bronchodilators. They only act by its anti-inflammatory action. Most effective in inhibiting airway inflammation, it acts through all the mechanisms of inflammation. So what is the anti-inflammatory effect in asthma? It produces modulation of cytokine and chemokine production. It causes inhibition of eicosanoid synthesis. There is marked inhibition of accumulation of the basophil, eosinophil and other leukocytes into the lung tissue. There is decreased vascular permeability and decreased edema is seen with the use of corticosteroids. It is most effective drugs used into the treatment of chronic asthma. So in acute asthma, we are mainly focusing on to the bronchodilation. In chronic asthma, we are mainly focusing on the inflammation part. Inhaled corticosteroid drugs are beclomethasone dipropionate, triamcinolone acetonide, budesonide, fluticasone propionate. They differ markedly in their affinity for glucocorticoid receptor, but all are equally effective in controlling asthma at equipotent doses. What is the current therapeutic status? They are first line of therapy for chronic stable asthma, and inhaled glucocorticoids are preferred. Systemic steroids are the first line therapy for acute exacerbation of asthma or acute severe asthma. They are preferred over beta 2 agonist for the prophylaxis. Beneficial effect will start within 1 week and bronchial hyperreactivity will be suppressed for several months with the continuous use. What are the adverse drug reaction of corticosteroids? It may go for 2 to 3 slides, but you will be learning about them in detail in endocrine system. But inhaled corticosteroid can lead to suppression of the immunity into the oral cavity, which lead to oral candidiasis. Hypothalamo-pituitary adrenal axis suppression, bone resorption and growth retardation, mood disturbances, increased appetite, dysphonia, impaired glucose control into diabetics, cataract, skin thinning and purpura. Now we see the next category of the drug, that is drugs acting on leukotriene pathway. They are drugs which are inhibiting the leukotriene synthesis, that include xylutone, which act by selectively inhibiting the 5-lipoxygenase enzyme and inhibit the production of leukotriene. And there are leukotriene receptor antagonists, that is montelukast and zeferlukast, which are competitive antagonists at LT1 type of receptors. Both groups are equally efficacious. All leukotrienes are potent vasoconstrictors, so they have role into the inflammatory cascade of airway also. These drugs can be given orally. What is the current therapeutic status of leukotriene inhibitors? They are effective for prophylactic treatment of mild asthma only. Can prevent the nocturnal asthma, exercise induced asthma and non-exposure induced asthma, which means these drugs are useful if you take the drug before the asthma attack starts, because they can inhibit the synthesis and they can block the receptor, but they cannot reverse the action of already produced leukotriene, or they cannot reverse the action of already combined combined with the receptor leukotrienes. So these drugs are useful as a prophylaxis. One should take the drug before the onset of bronchial asthma. Role into the moderate and severe asthma is not defined clearly, which requires further research. Montelukast and zeferlukast is given once or twice a day, while xylutone can be given 4 times a day. Adverse drug reaction are, they can produce systemic eosinophilia and vasculitis with features similar to Churg-Strauss syndrome. Elevation of liver enzyme is seen with the xylutone only. Liver function test needs to be monitored for first 2 months of therapy and at every follow-up visit thereafter. Other category of the drug is mast cell stabilizer. There are two, that is cromolyn sodium and nidocromyl sodium. What is their mechanism? They inhibit the mediator release from the mast cells, reversing the increased functional activation of leukocytes. They suppress the activating effects of chemotactic peptides on neutrophils, eosinophils and monocyte, and they inhibit the leukocyte trafficking into asthmatic airway. Pharmacokinetic is, they are not absorbed orally, given through inhalational route or topical into the eyes. Peak level is achieved within 15 minutes, half-life is 45 to 100 minutes. 1 milligram per puff is available and one can take 2 puffs 4 times a day. Therapeutic uses is, they can be useful for bronchial asthma, allergic rhinitis or allergic conjunctivitis. Basically, this stabilizes the mast cell and does not allow mediator to get released. So it can be useful for any allergic conditions. Adverse effects are infrequent and minor. It produces bad taste, bronchospasm, cough, wheezing, laryngeal edema, angioedema, joint pain and swelling, headache, nausea, rashes, and rarely it produces anaphylaxis, which is there into 1 in 10,000 cases. Another interesting drug is Ketotifen, which is as such antihistaminic, but it is having some chromoglycate-like activity. It reduces the stimulation of inflammatory and immunogenic cells, that is mast cells, macrophages, lymphocytes, neutrophils, etc., and also reduces the mediator release. It is having very less efficacy and not used routinely for the treatment of bronchial asthma. So what is the current therapeutic status of mast cell stabilizer? They prevent the asthmatic attack into the individual with mild to moderate asthma. They are ineffective in treating ongoing bronchoconstriction. They are helpful in reducing the bronchial hyperreactivity on long-term use. but they are less effective than corticosteroids. Nidocromil should be used only into the patients of more than 12 years of age, while cromolyn can be used for all age group patients. Next type of drug is anti-IgE therapy. The drug available is omalizumab, which is a biological drug produced by recombinant humanized monoclonal antibody which is targeted against IgE. IgE bound to omalizumab cannot bind to IgE receptors on the mast cells and basophils, thereby preventing the allergic reaction at a very early step into the process. Single subcutaneous injection every 2 to 4 weeks is sufficient. Peak levels are achieved in next 7 to 8 days and half-life is 26 days. Current therapeutic status, it is indicated for adult and children of more than 10 years with allergies and moderate to severe persistent asthma. Other allergic disorders like nasal allergy, food allergy can also be treated with this drug. Adverse drug reactions are injection at the site will produce redness, stinging, burning, induration, pain, etc. Low rising titers of antibody against omalizumab into the some patients have been seen because it itself is produced by recombinant DNA technology, and body will identify it as an antigen and produce the antibodies against this drug. Anaphylaxis reactions are seen in 2.1% of cases, and rarely it may lead to development of malignancies. So this finishes the discussion of different drug classes for the management of asthma. We have discussed bronchodilators, we have discussed anti-inflammatory drug which included glucocorticoids, mast cell stabilizer, leukotriene receptor antagonist and inhibitor of leukotrienes, and anti-IgE drug. Now we start with the management of asthma. So what is the goal into the patients of asthma? That first we should try to reduce the impairment by the patient. We prevent the chronic and troublesome symptoms. Require the infrequent use, that is less than 2 days per week of inhaled beta 2 agonist. We should manage the patient in such a way that he requires inhaler to be used less than twice a week. That is acute episodes are less into number. Maintain the normal pulmonary function so that long term complication does not take place. Maintain normal activity of the individual and meet the patient's and family's satisfaction level. And other important goal is reducing the risk. We try to prevent recurrent exacerbation of the asthma and minimize the patient's visit to the hospital, as well as the hospitalization numbers are reduced. Prevent the loss of lung function with minimal or no adverse effect of drug therapy and improved quality of life of the individual. First treatment is non-pharmacological therapy. For the treatment of bronchial asthma, we have two therapies. One is pharmacological therapy, other is non-pharmacological therapy. Non-pharmacological therapy is incorporated at all the steps of management. એવું નથી કે પહેલા non-pharmacological therapy try કરો પછી pharmacological આપો. You always give non-pharmacological therapy at all the stages of the management. Patient education about the basic facts of related to asthma, how asthma occurs, what happens into the airway, what are the actions of drug, and how it should be used. Role of medication should be explained in detail to the patient, that how the drug is acting, long term control is there, quick relief is there. Patient needs to taught about the skills of using inhaler, rotahaler and nebulizer. Environmental control needs to be teach to the patient, like you try to identify the allergen and avoid them, and give the follow-up advice after each visit to the doctor. For the drug related management, we first need to clinically stage the asthma and give the treatment according. So non-pharmacological advice is incorporated at every stage, and now we are seeing the stages of asthma. There are two types of asthma. One is intermittent asthma or acute attack, and second is persistent asthma or chronic asthma. which means in certain patient there is episodes of bronchial asthma occurring at less frequent interval, like once in every 3-4 months or twice a year. That is the frequency called as intermittent or acute asthma. And second is persistent or chronic asthma, where patient has underlying disease with overall exacerbation. This classification is based on the symptom frequency, nighttime awakening, requirement of the salbutamol, and level of lung function. Normal lung function is measured based on the FEV1 upon FVC ratio. Normal FEV1 upon FVC ratio for the age 8 to 19 year is 85%, 20 to 39 year is 80%, 40 to 59 year is 75%, and 60 to 80 years is 70%. So this is the component of the bronchial asthma. This is what happens into intermittent or acute asthma and persistent asthma. Symptoms are less than or equal to 2 days per week. Nighttime awakening less than twice per month. Shorter acting beta 2 agonist used for symptom control less than twice per week, and interference with the normal activity is none, and lung function is FEV1 is more than 80% and FEV1 upon FVC ratio is normal. This defines the patient as intermittent asthma or acute simple asthma. In persistent asthma, there are 3 subcategories: mild persistent asthma, moderate persistent asthma, and severe persistent asthma. If we see the symptoms in mild persistent asthma, they will be more than 2 days per week but not daily. In moderate, it will be daily, and severe, there will be daily but throughout the day. Nighttime awakening is 3 to 4 times per month into the mild persistent asthma. It is usually once per week into moderate asthma, and it is often 7 times per week or almost daily into the severe persistent asthma. Shorter acting beta 2 agonist used for the symptom control is more than 2 days per week but not more than once a day into the mild cases. In moderate cases, patient daily needs to take 1 puff of salbutamol. In severe, there are several times patient has to take salbutamol per day. Interference with the normal activity is very minor with the mild persistent asthma. There are some limitation with moderate persistent asthma, and in severe persistent asthma it is extremely limited. If we see the lung function, FEV1 is more than 80% and FEV1 upon FVC ratio is normal into mild persistent asthma, but FEV1 reduces to 60 to 80% in moderate persistent and less than 60% into severe persistent asthma, while FEV1 upon FVC ratio is reduced by 5% and FEV1 upon FVC ratio is reduced by more than 5% into moderate and severe asthma respectively. This is the management guideline. This one slide will give you the treatment of all the types of bronchial asthma. What are the type? One is intermittent asthma, mild intermittent asthma. You see only one drug here, short acting beta 2 agonist as required for the symptom relief. If patient is falling into category of intermittent asthma, he has to take salbutamol inhaler as and when required. Whenever bronchospasm occur, patient has to take shorter acting beta 2 agonist by inhaler. Second category is mild persistent asthma. As we go on this side, the severity of disease increases, and on this slabs the number of drugs used are increasing. You can remember the treatment like this. For mild persistent asthma, there is one step only. That is why it is called a step ladder pattern. With every increment into the severity of disease, there is increment of the drug class which is added for the treatment. For mild persistent asthma, one has to start with the low dose inhaled corticosteroids daily along with shorter acting beta 2 agonist as and when required, because glucocorticoids are not bronchodilators. You start with the low dose of inhaled glucocorticoids which can suppress the inflammation because patient is into the stage of persistent asthma. But whenever there is acute need, You have to give beta 2 agonist, that is as and when required, and it remains the same for all the stages of asthma. In moderate persistent asthma, you give inhaled corticosteroid into low doses, or you increase the dose to the moderate level, and you add longer acting beta 2 agonist along with it, like salmeterol, or this is the drug which is added to the inhaled corticosteroid into the moderate persistent asthma along with beta 2 agonist as and when required. So here there are three steps: beta 2 agonist, inhaled corticosteroids, and longer acting beta 2 agonist. In severe persistent asthma, inhaled corticosteroids are to be given at the highest possible dose, and longer acting beta 2 agonist dose needs to be increased along with beta 2 agonist as and when required. And in very severe persistent asthma, inhaled corticosteroid at high doses, longer acting beta 2 agonist at their maximum doses, along with it you start with the oral corticosteroids, that is oral tablet of glucocorticoids needs to be started. This approach is called as step ladder approach for the asthma, which is asked as a full question into the exams also. Now we come to the last part of the bronchial asthma, that is acute severe persistent asthma or status asthmaticus. There is a slight difference between the acute intermittent asthma and acute severe persistent asthma and status asthmaticus. Acute asthma means mild intermittent asthma, you only have to give beta 2 agonist. But when the term acute severe persistent asthma is there or status asthmaticus is there, it is a medical emergency. You have to rush to the hospital to save the life of the individual. Here FEV1 or peak expiratory flow rate is less than 50% of the predicted value for that age and gender. There is severe symptoms at the rest along with the chest retraction. You can visibly see the chest is retracting and coming out with the each breathing. There is no improvement after initial treatment of inhaled beta 2 agonist, oxygen, or systematic steroids. So here the goal of therapy is, first you have to correct the hypoxia, and you have to start with the rapid reversal of the obstruction. So treatment, first we have to give hydrocortisone 100 mg intravenously stat, followed by 100 to 200 mg 4 to 8 hourly, because it will take 6 hours to start its action. You hospitalize the patient, you take a IV line, start a drip of IV fluid, and along with it you give hydrocortisone, you withdraw blood sample for the investigation, and you start with the hydrocortisone. Secondly, you give nebulized form of the salbutamol into the dose of 2.5 to 5 mg in combination with ipratropium bromide 0.5 mg, which is given along with the intermittent driven oxygen. Here patient is into the severe respiratory stress condition. He cannot coordinate or he cannot breathe by himself. If patient is not breathing at all, how can we advise the patient to take meter dose inhaler and coordinate the administration of meter dose inhaler? Patient may be unconscious at this stage, so better you give nebulizer. Nebulizer is an electronic device which will take the desired drug or the filled drug directly into the respiratory tree. So salbutamol along with ipratropium bromide is to be given by nebulized form, along with you give oxygen as and when required. High flow humidified oxygen is to be started only after salbutamol, because now the bronchus are dilated and oxygen will reach the blood. Once you have given injection of hydrocortisone, you can start with the inhaled corticosteroids which patient is taking regularly. If still patient is not controlled, you give everything, still you observe the patient and patient is not controlled, then IV injection of xanthine derivatives or theophylline may be thought into resistant cases. Suppose you have given one injection of theophylline over 40 minutes with cardiac monitoring and everything, still patient is not improved, he is breathing problem, severe hypoxia, then last resort is you intubate the patient and put the patient on mechanical ventilator if required. You have withdrawn the blood sample, you start the treatment for the chest infection if it is there into the report. So chest infection is to be treated by antibiotics if required. Because the patient is exerting, he is into the dehydration stage, and there is a respiratory, first there is metabolic acidosis, then respiratory alkalosis, which needs to be treated with IV fluids. So this finishes all the aspects of management of bronchial asthma. Thank you, and if you have any questions you can ask. Thank you so much.